Good morning. I would like to thank the organizers for the invitation. My topic is risk-adapted axillary surgery, including targeted axillary dissection and its practical aspects. I will focus on patients who are node positive at presentation and undergo neoadjuvant chemotherapy. Management of the axilla has changed over the last 10 to 15 years. Axillary lymph node dissection has significant arm morbidity. 1 in 5 patients are at risk of lymphedema. Sentinel lymph node biopsy has replaced axillary lymph node dissection in node-negative patients and in patients with low-volume nodal disease, such as micrometastasis, and patients with 1 or 2 macrometastasis, where axillary radiotherapy has replaced lymph node dissection based on the AMAROS trial. The goal is to minimize arm morbidity of axillary lymph node dissection without compromising the outcomes. The topic of this talk is node-positive patients at presentation and their axillary management following neoadjuvant chemotherapy if they have a complete nodal response. We tried to document the current practice in the country. As part of the NACT trial feasibility survey, we asked sites what's their standard of care if the patients had a complete nodal response to neoadjuvant chemotherapy. 50% of sites would perform lymph node dissection, 30% would give radiotherapy to the axilla, around 15% will do lymph node dissection or give radiotherapy to the axilla. Only 1% of sites would omit axillary treatment in these patients. We are observing increasing PCR rates with neoadjuvant chemotherapy. In this paper, which includes 7 randomized trials between 1998 and 2006, the highest response rates were seen in patients with HER2-positive tumors, non-luminal and triple-negative tumors, and that's what we see these days. But the response rates are likely to be higher today based on the newer drugs in the region of 50 to 60% in these subgroup of patients. So the question is, if patients have a complete nodal response with neoadjuvant chemotherapy, even though they are node positive to start with, can we omit or change axillary treatment? The Netherlands Cancer Registry data showed that 45% of patients with breast PCR also had a nodal PCR. Again, this data was based 2010 to 2016, and therefore higher rates of nodal PCR would be expected today with newer drugs being used for neoadjuvant chemotherapy. So to come to the question, can we change axillary treatment in patients who have a complete nodal response following neoadjuvant chemotherapy? The key thing is to accurately stage the axilla following neoadjuvant chemotherapy with a minimal false negative rate with sentinel node biopsy. The acceptable standards that we have used for surgery first trials, such as Almanac and NACT, were false negative rate of 10% or less, a node identification rate of 90% or more. If you look at the NACT B18, B27 data, they found that patients who remain node positive following neoadjuvant chemotherapy have a very high local regional recurrence rate, even with smaller tumors, if you look at the line here. And therefore, it's critical that the false negative rate in this subgroup of patients who are node positive to start with is minimal. There have been 4 prospective studies looking at the false negative rate of sentinel lymph node biopsy in this setting. The Z1071 study, Sentina, SN-FNAC, and the French study. All the studies had a higher false negative rate compared to the surgery first studies. The false negative rate ranged between 12 and 14%, except for the Canadian study where the false negative rate was in single digits. In this study, IHC was used to assess the lymph nodes, and therefore that's one of the take-home message that IHC can be used to reduce the false negative rate. All the 4 studies consistently showed that if you take 2 or more lymph nodes out, you can reduce the false negative rate to single digits. If you look at the recent meta-analysis published in 2018 that included these 4 prospective studies and other studies, the false negative rate when 1 node was removed was 20%, and this dropped down to 4% when 3 or more nodes were removed. This is no different from the Almanac trial, which was the surgery first trial. The false negative rate was 10.1% when one node was removed, and this dropped drastically to 1.1% when 3 or more nodes were removed. The same meta-analysis showed that if you use a dual tracer sentinel lymph node mapping, you can reduce the false negative rate. The false negative rate in this meta-analysis with dual tracer was 11% versus 19% with single tracer. So what next? Can we reduce the false negative rate in this group even further? Because overall, the false negative rates after neoadjuvant chemotherapy in patients who are node positive to start with are higher compared to patients who are node negative at presentation, undergo neoadjuvant chemotherapy, and then staged by sentinel lymph node biopsy. The answer appears to be targeted axillary dissection. This involves marking the involved or the cancerous node before the patient starts neoadjuvant chemotherapy. The patient's given neoadjuvant chemotherapy, and then the axilla is staged with sentinel lymph node biopsy. But the surgeon also, in addition to the sentinel lymph nodes, removes the marked involved node. Looking at the MD Anderson data, the false negative rate for sentinel lymph node biopsy alone was 10.1%. If only the clip node was taken out, this was 4.2%, and the combination yielded a false negative rate of less than 2%. A more recent meta-analysis published in 2021, the false negative rate when the marked node alone was removed was 6.28%. When this was combined with sentinel lymph node biopsy, which is targeted axillary dissection, the false negative rate dropped to around 5%. And these false negative rates are acceptable if you compare them with the surgery first trials. The NSABP 32 false negative rate was 9.8%, Almanac 6.7%, New Start training program that we published a few years ago, 9.1%. So what we have seen here is that the false negative rate in patients who are node positive to start with, have neoadjuvant chemotherapy, and are planned to undergo sentinel lymph node biopsy can be reduced if you use a dual agent mapping, remove 3 or more sentinel lymph nodes by marking the involved node before the patient starts neoadjuvant chemotherapy, and then removing this node in addition to the sentinel lymph nodes. By imaging the axilla after neoadjuvant chemotherapy to assess the response in the lymph glands, as if the patient has a poor response in the lymph glands, this patient can proceed to lymph node clearance rather than targeted axillary dissection, and if possible, include immunohistochemical staining when assessing the lymph nodes after neoadjuvant chemotherapy in targeted axillary dissection. The key thing to remember here is that not all patients will have 3 sentinel lymph nodes. If you look at the median number of nodes removed in the Almanac trial, it was around 2, and a very similar figure in the New Start training program. And therefore, the third node that the surgeon will need to remove will have to be sampled, and this is acceptable. How to mark the nodes? There are various techniques that you can use. Clips, coils, black dye that we use in Darby and Burton, MagSeed, SaviScout reflector, Sirius pentution system, which is a magnetic seed, radioactive iodine, and the radio frequency tag. If your site is considering adopting targeted axillary dissection, some practical tips. On patient selection, the appropriate candidates are T1 to 3 N1 M0 patients. When the patient has an axillary ultrasound at presentation, the radiologist should document the number of abnormal nodes seen on ultrasound scan in all patients undergoing a lymph node fine needle aspiration or biopsy. It's helpful to document if the number of abnormal nodes are 3 or less or more than 3, as this will help you to differentiate between N1 and N2 disease. It's helpful if the radiologist can document and capture images of the location of the biopsied node, as if this node turns out to be positive or malignant following histology, then when the patient comes back for marking the node, a second radiologist, if it is not the same radiologist during that visit, is able to locate that node with ease. How do you assess whether this is N1 or N2 disease at presentation? We suggest you count the nodes that score 4 or 5 on imaging. you do not count the nodes which are indeterminate and score 3. If you see multiple abnormal nodes on imaging with score 4 or 5, you do not need to mark all the nodes. You can mark the involved node that was biopsied. It is helpful to document on the operating list that the surgeon needs to remove at least 3 nodes when listing the patient. And a tip for the surgeon, when in doubt that what you have removed is a piece of fat or lymph node, it's better to remove 4 rather than 3 nodes. It's helpful for the pathologist if you highlight on the form that this is a post-neoadjuvant chemotherapy patient and request the pathologist to comment on signs of downstaging in the node. For sites where the standard of care in these patients is lymph node dissection, I would strongly encourage to participate in the NACT trial, as participating in the NACT trial will allow you to adopt the node marking technique in a safe manner. We have training resources that we'll be able to share with you. At Darby and Burton, we mark the node using black dye. It's a sterile carbon suspension. It's marketed as black eye with 1 ml syringes and spot dye in 5 ml syringes. I would strongly recommend using 1 ml syringes for the radiologist, as it gives better control when injecting into the node and avoiding spillage into the surrounding axillary fat. This has been used widely to mark polyps or tumors when doing endoscopy. It has been used to mark non-palpable breast lesions and lymph glands in other studies as well. It is cheap and cost-effective. It comes to around £10 per syringe. We conducted the multi-center feasibility study to standardize the technique to mark the node using black dye. This was the pre-NACT trial that we published. The key findings were that the tattooed node was identified in more than 80% of patients at the time of surgery. Tattooed node was the sentinel lymph node in 80% of patients, which is consistent with other studies. The identification rate did not vary with timing between dye injection and surgery. The volume of dye injected, body mass index, and there was no learning curve. But the key thing regarding volume is that if you use more volume, it causes spillage in the axillary fat, and this makes for the surgeon, it's very difficult to visualize the nodes. The standardized technique that we would recommend based on the pre-NACT trial is, if you're planning to use carbon suspension, is to inject only 0.2 to 0.4 ml, depending on the size of the node. If it's a small to medium sized node, I would recommend injecting 0.2 to 0.3. If it's a large node, you inject 0.4 ml. Before you inject into the node, I would recommend that you use a 1 ml syringe and you discard 0.6 ml so that it prevents any spillage or accidentally more dye, if it prevents more dye being injected into the node. You need to inject only in one place in the cortex. You can inject at the time of biopsy or fine needle aspiration, or you can inject at a separate visit. And we have shown in the pre-NACT trial that this is feasible. We do not recommend injecting around the node or in the nodal tract or in the biopsy tract, as this causes spillage of the dye into the axillary fat, making it difficult for the surgeon to identify the nodes. The pathway we use at Darby and Burton is, once we know the node is malignant and the patient's going for neoadjuvant chemotherapy, the node is marked using black dye. The patient finishes neoadjuvant chemotherapy and undergoes dual tracer sentinel node biopsy, where the surgeon removes at least 3 nodes. As we have seen in the pre-NACT trial, 80% of cases, the marked tattooed node will be the sentinel node. If you see multiple black tattooed nodes because of dye migration, which can happen sometimes, the surgeon can stop after removing a total of 4 nodes. Alternatively, you could inject the black dye at the time of node biopsy or fine needle aspiration. However, I feel that this pathway is not pragmatic and increases the workload for the radiologist. Other simple technique is to use clips, which are easily there in your breast unit in the radiology department. You can place the clip once you know the node is malignant and the patient is planned for neoadjuvant chemotherapy into the node. You could use the standard Hydromark clip, and there are newer clips and coils that you could use. Once the patient finishes neoadjuvant chemotherapy, the patient undergoes dual tracer sentinel node biopsy and at least 3 nodes are removed. You can do a specimen X-ray in theater to confirm that the clip has been removed. If no clip is seen, the surgeon can stop after taking a total of 4 lymph glands. Again, to help the surgeon identify the clip or the clip node, you can skin mark the clip or the clip node, or you could inject a black dye to tattoo the clip or the clip node. The clip can be placed at the time of node biopsy, like we discussed when we were discussing the black dye pathway. However, again, I feel that this is not pragmatic and increases the workload for the radiologist. There are newer wireless localization techniques for the breast, and if your site is using these techniques to mark the breast lesions or is planning to uptake one of these techniques, then it makes sense to use that technique and to integrate that into the node marking pathway. There's mag seeds, Scout reflector, Sirius Pentition system, radioactive iodine seeds, and the localizer. Radioactive iodine seeds, they have issues with RSEC licensing, and looking at that, my feeling is that very few sites would like to take that up for node marking. So this is for sites who are using the wireless localization technique for breast lesions, or they're planning to do that. So one pathway is that once you know the node is malignant, you could insert the wireless marker into the involved node. Patient undergoes neoadjuvant chemotherapy, and then a sentinel lymph node biopsy, which could be a single or dual tracer, and removal of the marked node. A more cost-effective option is to place a clip once you know the node is malignant instead of the wireless marker. The patient has neoadjuvant chemotherapy. You assess the response, the nodal response on imaging. If there is a good response, then you could place the wireless marker to mark the clip or the clip node, and the patient undergoes targeted axillary dissection. However, if imaging shows that there is no good response in the axilla, then this patient can proceed to lymph node dissection rather than marking the node with the wireless marker. So once you have removed the nodes, perform the targeted axillary dissection. On histology, if you see residual nodal disease, which is isolated tumor cells, micrometastasis, or macrometastasis, the standard of treatment remains axillary lymph node clearance. If there is no residual nodal disease, that includes, again, isolated tumor cells, micro or macrometastasis, this patient would still be advised further axillary treatment in the form of axillary radiotherapy outside trials. If your site is participating in the NACT trial, then this patient could be randomized to axillary treatment or omitting axillary treatment. Axillary treatment can be radiotherapy to the axilla or lymph node clearance. The reason we included lymph node clearance was for sites who wish to use OSNA to assess the nodes intraoperatively and wish to proceed with lymph node dissection rather than giving radiotherapy to the axilla. ATNAC trial is a multi-center UK trial which is trying to answer the question whether we can omit axillary treatment in patients who have a complete nodal response following neoadjuvant chemotherapy. Currently, we do not have that data. The trial includes T1 to 3 N1M0 patients. We strongly recommend marking the involved node before neoadjuvant chemotherapy. Following neoadjuvant chemotherapy, the patient undergoes breast surgery and sentinel lymph node biopsy with removal of the marked node. You can still participate in the study if you do not plan to mark the node. Marking the node is not mandatory. If you're not marking the node, the surgeon performs a dual tracer sentinel node biopsy and takes at least 3 nodes out. If on histology there is no nodal metastasis, the patient's randomized to axillary treatment or no axillary treatment. The way I see it working is that if the patient is randomized to axillary treatment, the patient will receive radiotherapy to the axilla. For sites where the standard of care is lymph node clearance, at the moment, this is a win-win situation for the patient, as the risk of lymphedema with radiotherapy compared to lymph node dissection is less, as we know from the AMAROS trial. So the way I tell my patients is, because our standard of care at Derby and Burton is lymph node dissection, so all patients, when they're offered the study, they are advised that the standard of care is lymph node dissection, and the study offers you the opportunity that If there is no residual cancer in the lymph glands after neoadjuvant chemotherapy, the computer will randomize to either omitting axillary treatment or you will get radiotherapy to the axilla. And in both cases, the risk of lymphedema is less compared to the standard of care. If the patient has residual disease following neoadjuvant chemotherapy, on sentinel lymph node biopsy / targeted axillary dissection, you can perform your standard axillary treatment at your site. We have training workshops. Our first virtual node marking training workshop was conducted last year. Those who missed it are still able to watch the virtual workshop or webinar on YouTube. We can send you the link. Please get in touch with me or the email address shown here for the trials unit. We have industry collaboration with Magseed, Savvy Scout, and Sirius so that we can provide your site a marker free of cost to mark the involved node if that particular patient is recruited in NACT study. We are collecting prospective data on different marking techniques, and the trial results will help to evaluate or compare the different node marking techniques to inform clinical practice. If your site would like to join the NACT trial, we are open to new sites. Please get in touch with me or the email address for the trial manager shown on the slide. This is just a summary of other ongoing trials apart from NACT. The NSA-BP B51 study is very similar to NACT, where patients with no residual nodal disease are randomized to regional nodal radiotherapy versus no regional nodal radiotherapy. The Alliance 11202 study is for patients who have residual disease after neoadjuvant chemotherapy in the lymph glands. These patients are randomized to lymph node dissection versus radiotherapy to the axilla. So to conclude, the nodal complete response rates have increased with advances in neoadjuvant chemotherapy, marking the involved node before neoadjuvant chemotherapy and then removing it at the time of sentinel lymph node biopsy helps to reduce the false negative rate to less than 5%. We do not have a long-term data on whether we can change axillary management in patients who do not have any residual disease following targeted axillary dissection. These patients will be advised radiotherapy to the axilla outside trials. NACT trial in the UK is trying to answer the question, and I would strongly encourage your site to take part in the study. We already have 35 sites which are open to recruitment. We have a total expression of interest till now from 95 sites, and more sites will be open later this year. And we would welcome if your site would like to join us. Lymph node dissection remains a standard of care for patients with residual nodal disease on targeted axillary dissection after neoadjuvant chemotherapy. The trial is underway to determine if radiotherapy to the axilla can replace lymph node dissection in this subgroup of patients. Thank you very much.